Oh, they're talking about making Juneteenth a federal holiday.
I think they passed that, right? Or
We're live now, just so everyone knows.
Sure.
so far it's just the three of us. Oh. Are you able to put this in slideshow mode, Stephanie?
Yeah. Mm-hmm.
Perfect. Thank you.
First one,
Now, let me get
turn off my
your
camera.
thoughts on this historic day. What do you think?
You know, Wolf, we have covered these incredible summits for the last many, many decades. I think first we have to acknowledge that President Biden's job is to defend democracy against rising autocracies around the world. That he did something very different than President Trump. Instead of going to an adversary like Saudi Arabia as his first foreign trip, he went here to Cornwall and the G7 to allies, then to NATO in Brussels, then on to the EU summit, gathered all his backers, all his team, so to speak, behind him before going to talk to President Putin. There is no way that anybody expected that either Putin and Biden were going to resolve their massive differences, whether it's over 2 hours, 2.5 hours, 5 hours, or what. And so we really do have to see what are the crumbs or what are the...
Danny, the questions that were sent yesterday, do you want me to ask those in the training, or do you just plan to bring those up?
I plan to bring them up.
Okay.
But if I don't address them, it's going to be in the ADHD part.
Okay.
You let me know if you know, if I don't do enough with them. You just stop me.
Okay. Sounds good.
Oh, 2 men kicked off the plane for fighting over elbow rests. It's about time.
Hot news day today.
Yeah, I can't tell you how many times aisle gets the leg room, window seat gets the window, middle seat gets 2 armrests. That's good. Yeah, they are packing people in like sardines. I always hate that.
Yeah, it's definitely a tight squeeze.
Yeah. Anyway. All right. So I have 12:58.
That's what I have. I see 3 people logged in, so let's go give a couple more minutes till we're officially at 1. For those of you who are already on, if you have any like questions you want to send to Danny in advance so he can address them in the training, you're welcome to send a Q&A or a chat that way too.
Whoops, I just lost the. There we go. I'm not as good at Zoom as I should be.
After a year?
Well, you know, I don't pay that much attention to it.
That's true. You just kind of hit start and yeah. I'm comfortable with like the features I use all the time, but outside of that, I'm probably not very good at it either. Getting a couple more people logged in here.
Stacy, who helped with the slides this time?
Stephanie did.
Okay, great.
All right, we're at 1, and we have a good amount of people logged in. So we'll go ahead and just get started with the logistics, and hopefully a couple more people will roll in here. Welcome everyone to Danny's training, Balancing the Risks and Benefits of Psychotropic Medications for Children and Adolescents. As usual, I have a couple logistics to go over for APA. First of all, I think we're all used to this. Everyone's microphones are muted. If you have a question, use the Q&A or chat feature. If you have any technical issues, you can message or you can text me. I'll put my number in the chat, or you can call Stephanie too. Both of us are here to help. Yesterday we sent out the handouts and the reference list. You should have received those in email. Sometimes these are going into spam with the filters set the way they are right now. So if you didn't get it, check there. And if they're not there, just let us know and we'll get those sent to you right away. This training is recorded, and this training is approved for 1 continuing ed credit for psychologists. Unfortunately, that does not apply for New York psychologists just yet, but we are very close to getting our approval from New York State. So hopefully future trainings will be set for all psychologists. If you're not a psychologist, you can just use the certificate of attendance to see if your board accepts CEs from APA approved sponsors, and everyone will get their certificate of attendance emailed to them after the training. Again, check spam if you don't get it. Full attendance is required to get continuing ed. There are no conflicts of interest or financial disclosures for this training, and evaluations will also be emailed to you after the training. All right, those are my logistics. Danny, it's all yours.
All right, thanks a bunch, Stacy. So there you go. All right, stop right there. Oh, go back 1, Stephanie. Thank you. So I want to start off by really thanking Stacy and thanking Stephanie for helping to make this possible, and encouraging all the participants to let Stephanie know, both if you have questions as the talk is going on, but also if you have topics or areas that you'd like me to cover in later talks. Next slide, please. So obviously, I'm not going to be able to cover everything that you would need to know to be completely informed about making decisions about medication. The idea is that I'm going to give you an outline about how to broadly think about this choice, about balancing safety and efficacy, and I'm going to really cover the most common questions that come up with the kind of patients that we see at the Ross Center. And I'm going to do this in a way that, on the one hand, reviews data on efficacy, meaning how much a medication works for a disorder, how much clinical benefit it has. On the other hand, against the data on safety. How much data are there on safety? What are the major safety concerns? Now, as you'll see in a minute, this really is about more than just data on safety and efficacy, that anytime we make questions about or pose questions about treatment for any disorder, it's posed in the context of what we know about the disorder. How serious is the disorder? What are the alternatives that we can possibly do? And so I'm really going to emphasize that throughout the talk. Next slide, Stephanie. So this gives you the outline of the talk as it's going to go. I'm going to begin by talking about this broad perspective that I alluded to, and then I'm going to go through these 5 categories of conditions. One topic that is going to be implicit in a lot of what I say, which I would like to devote more time to, is the issue of diversity. So there has been a tremendous amount of research on aspects of underserved populations and aspects of diversity. And what we find is that these groups tend to not get the established evidence-based treatments to the same degree that children who are more in the mainstream. So in terms of getting treatments into the hands of children who need them, that's where issues of underrepresented minorities and families with special needs and children living under stressful circumstances, that's really where things come up short. As I talk about safety and efficacy, most of the data that we have suggests that in the children who are enrolled in the clinical trials that I'll be describing, there's no moderating effect in terms of the impact on either safety or efficacy. So I think the main thing that we can say about diversity is that we need to do more to get the effective treatments that I'm going to talk about into the hands of these children. All right, so let's begin by giving some other broad perspectives on how we think about decision making. Next slide, in terms of decisions on medication and relative to the other treatments that we have. Next slide. So in thinking about medication, there's kind of a historical setting in which we place our findings. And that really begins with a focus on phenomenology and the prevalence of different kinds of problems, particularly in psychiatry and also in psychology. And this really came to a head in the 1970s and culminated with the publication of DSM-3, which happened in 1980. And at the same time that there was a focus on phenomenology and epidemiology in psychiatry, the importance of approval by the Food and Drug Administration for treatments in all of medicine was also becoming a major issue. And the government, through the NIH and also through the FDA, increasingly recognized the randomized controlled trial as the gold standard of evidence in terms of thinking about safety and efficacy. So the things that I'm going to be spending most of the time describing are large-scale randomized controlled trials. Now, when we talk about efficacy research with medication, we talk about phases. And this is terminology that was used a lot during the pandemic, and you should become familiar with the 4 phases of FDA research. Phase 1 is what we call first in humans. That's typically the first time anybody takes a medication, and it's really just for safety and tolerability. Phase 2 are what are typically called early preliminary efficacy trials. So the kind of studies that I do at the NIH are mostly phase 2 trials, early efficacy trials. The really important studies are what we call phase 3. So you might have heard when people were talking about the vaccine for COVID, everybody was talking about the results of the phase 3 trials. And that's typically what the FDA uses to approve a medication. Now, one of the main problems with this pathway is that many treatments, really in all of medicine, but particularly in psychiatry, fail at phase 3. And that's a really bad thing, partly because people get their hopes up, partly because a huge amount of work has already gone into a study when it gets to phase 3, and partly because it's really bad for the pharmaceutical industry. And the failure of medicines at phase 3 has been a bit of a crisis in psychiatry for the last 10 years. And it reflects the immature state of clinical neuroscience, that clinical neuroscience has by and large had really no impact on how we think about wide-scale novel treatments compared to serendipitous clinical observations. Now, the bulk of what I'm going to talk about is going to relate to a series of studies that really began in the late 1990s and early aughts. And these studies were funded when Steve Hyman was the head of the National Institute of Mental Health. And these were large scale, meaning many hundreds of children were included in them, large scale comparative efficacy studies. And what that means is that individuals were randomized to different treatments, many of which might be efficacious. And when you're in training, you really need to be familiar with what are these large scale efficacy studies and what were the bottom lines, both how did they come about and what did they teach us? And that's really what I'm going to be going over. Next slide. So as I mentioned, we don't make these decisions in a vacuum. They really relate to the nature of the disorder. Disorders that are more serious, that tend to have major health consequences, that tend to be chronic and tend to remit, not to remit, we have a lower threshold for considering potentially dangerous treatments as compared to milder problems. So this is why the threshold for approving a new medication for a very serious condition is lower. And this is also the kind of thing that's frequently in the news. You might have heard about this controversy about this new drug, new medication for Alzheimer's disease, which was approved by the FDA a couple weeks ago. And the controversy related to the fact that the evidence of efficacy was pretty weak, but the drug was approved nonetheless because this is a very serious disorder where there's no real established treatments, and therefore we're willing to accept a treatment where the evidence is fairly weak. So the same thing is true when you think of mental health disorders. And for example, when we think about a treatment for specific phobia, a relatively mild condition, the threshold for demonstrating efficacy is much higher than if we think about a serious condition like autism spectrum disorders, where there are no medications that have been shown to alter the primary underlying symptoms. So typically what we do with these data in the context of considering the seriousness of the disorder is the first thing we do is look at the data from safety and efficacy studies that just compare medications with placebo. Now, for all the things that I'm going to be talking about, except one condition, and that's autism spectrum disorders, there have been a lot of studies that have demonstrated safety and efficacy from placebo-controlled trials. So I'm really not going to talk about those in much detail at all. What I'm going to talk most about is efficacy data that compares psychotherapy to medications in randomized controlled trials. And as a psychologist, these are the data that you really need to be familiar with, because this should really influence your thinking in terms of how soon I should really start thinking and talking about medications. And these kinds of studies that compare psychotherapy with medication, we call those comparative efficacy trials. They're typically extremely expensive, and typically they're not funded by the pharmaceutical companies. Typically they're funded by the National Institute of Health, and typically they're the kinds of studies that set the standard of care, and that's why you need to be familiar with them. Okay, next slide. All right, so we're going to talk about ADHD, and we're going to talk about these data from these comparative efficacy studies. Next slide. So as I mentioned, we think about comparative efficacy data from the context of the severity of the disorder. ADHD is typically thought of as a moderately severe disorder. However, it's one where spontaneous relapse over months to a couple of years is relatively rare. So particularly in young children, it tends to be a persistent disorder. There's some controversy over longer time periods about how persistent ADHD really is, but in the short term, it's reasonably persistent. There are just oodles and oodles of data from randomized controlled trials. I'm not going to be able to review all the data, but it's very, very clear that there are 3 families of medications that are effective for the treatment of ADHD. I'm going to talk about one family, the stimulants, and that's because that's the most frequently studied treatment, and it's also the one treatment that's been compared with psychotherapy. There's also a lot of evidence from psychotherapy studies, and in this area, probably the most important study that has been published is something called the MTA study, or the Multimodal Treatment of ADHD study. And this was a study that began in the 1990s, and there's still many, many papers being published on this study. I just accepted a 20-year follow-up paper in the American Journal of Psychiatry on the MTA study. Next slide. So the first big papers from this study were published in 1999, and this enrolled kids who were between the ages of 7 and 10. There were approximately 600 kids, and if you look at the top left figure, yeah, right here. Can people, Stacy, can you see my arrow or no? You cannot?
I don't think, oh no, yeah, we can.
All right, move it up.
Yep.
So move it up. Yeah, right there. There you go.
Up right here.
So yeah, so look at right there. That shows you the 4 groups. And these 579 kids at multiple sites were randomized to one of these 4 groups. Community care. What that meant was you had an evaluation, and the evaluation was given to a provider in the community, and then they took over from there. The important thing to know is that 3/4 of the kids immediately in this community care immediately received medications. Below the medication group, you can see in the triangles, that's the gold standard parent management training and cognitively based psychotherapy for ADHD. Below that one is the medication alone group. And then below that one is the group that included both medication and psychotherapy. So there are 3 big things to say about the MTA study. The first is it's one of these studies that was done by community and by a lot of different scientists. And because of that, the message sometimes got a little more garbled than I would have liked it to be. But the results from the study were actually quite clear. And if you focus on that top left panel, you can see, yeah, right there. You can see that the top 2 lines, that shows you the reduction in teacher-rated hyperactivity and impulsivity symptoms. All right, those are the main symptoms that were targeted. And then as you can see, those 2 groups are higher than the other 2 groups, the combined treatment group, all right, and the medication group. So conclusion number 1 is that medication is more effective than psychotherapy. People didn't like to say that, but that's what that slide really shows you, that for the treatment of ADHD in this gold standard study, stimulants were more effective than psychotherapy. And that means that if you're a therapist and you have a child with new onset ADHD, you really need to think about medication. Does this child need medication or not? All right. Stimulants are also relatively safe treatments. So again, the decision for thinking about medication, both in light of this efficacy data and the safety data, are really pretty clear here, that you need to think about medication. Point number 3, and in some ways, this was the most interesting finding, if you look at the top line, kind of Stacy or Stephanie, highlight that top line. Yeah, right there. Yeah, no, go down. Yeah, right there. So that is the community care line. Those kids were on medication. Oh, go back. Yeah, right there. Those kids were on medication. So there was something about the way that the psychiatrist provided the medication that had a bigger effect on the symptoms. And there are a lot of questions about that, what that was. The kids who were seen by the psychiatrist got higher doses. The families were generally more compliant, and psychiatrists tend to make other recommendations besides medication. The last thing to say is that there has been a lot of attention called to what are called the moderators, and that means that people who like complicated stories did not like to make the emphasis about this study that I made, that's a relatively clear story, stimulants work. They like to talk about the different kinds of children where the story is more complicated. So if you look in the top right, highlight the top right one. Yeah, so yeah, right there. So if you look at the triangle line, you see how it falls right in the middle there? That there was more evidence that in children with internalizing symptoms that psychotherapy had a bigger impact. So, I'm comfortable saying that the other conditions that the child has do impact this decision about, what psychotherapy has to add. Though there are some questions really about these data. But the important thing that you need to know is the questions in a child with ADHD really go beyond medication, that every child with ADHD needs a serious thought about medication. If there are other problems besides the ADHD, then the discussion about what else do you do becomes more complicated. Two last points to say, and this was to say, I got some wonderful questions about this slide. So I'm just going to go into them. One question was, what do you do with a child who is younger than the age that the children in the MTA study were, and that these kids were younger than 7. Well, it's not so simple when you're younger than 7, because there was another study that was done in younger children with ADHD, children between the ages of 4 and 7. And stimulants were not as efficacious in those younger children. And we can talk about why that was. So it's probably worth a whole separate discussion about thinking about medication in young children. But the bottom line from that discussion is you need to be more cautious in young children with all medications, but that also includes stimulants, both because they tend not to work as well, but also because the younger the child, the more vulnerable we view them in general. The other question that was raised was about long-term treatment and how long do we continue to provide stimulants, and this is another question where we could have a whole discussion about long-term use of medication. And about 2 years ago, when we first started doing this, I had us read a study about chronic treatment for ADHD. Each disorder is a little different in terms of how careful we need to be about long-term treatment. ADHD is one of those conditions where we tend to feel more confident in providing long-term treatment. That's both because of what I said at the beginning about the condition, that it tends to be relatively persistent over a couple of years, but also long-term efficacy trials have been done, and they show even after 2 years of continued treatment, children still derive benefit. So for myself, after a year, I typically like children to have a trial off of medication. But again, it's the kind of thing where the data are less definitive than what I've been talking about so far. So I thought maybe I'd stop there just to see, Stacy, if you or anybody else want me to say anything else before we go on to conduct disorder and oppositional defiant disorder.
I don't have any questions yet. I'll let you
Okay.
know if any pop up.
All right, let's go to the next one. So conduct disorder and oppositional defiant disorder are both similar to ADHD in that many children with conduct and oppositional defiant disorder also have ADHD. So the questions about medication are quite similar, but it's also different because remember we talked about the MTA study, and remember we talked about moderators. Conduct and oppositional defiant disorder were one of those areas where psychotherapy again was shown to have a bigger impact in children with ADHD and conduct and oppositional defiant disorder. Next slide. So again, in this area, we need to think about the nature of the disorder. Like ADHD, conduct and oppositional defiant disorder is a relatively severe and relatively persistent disorder. However, compared to ADHD, there's more heterogeneity in terms of the kinds of children that we see. And throughout DSM-4 and DSM-5, there have been different clinical features that people have used to classify this heterogeneity. One is age of onset. We tend to think of children who develop signs of conduct disorder before the age of 10 as having early onset conduct disorder. And that tends to be a more serious and more persistent disorder, though the data aren't as clear as we'd like them to be. It also tends to be more often associated with ADHD. After 10, those two issues tend to be less true. Similarly, in DSM-5, callous unemotional traits, or what is called low prosocial emotions, were added, and those children also tend to have a worse prognosis. There's clearly less data overall on medications for the treatment of conduct and oppositional defiant disorder, and I think the decision is more complicated in conduct disorder and oppositional defiant disorder than it is for ADHD, particularly in children who do not have ADHD. So in children who have ADHD as well as conduct disorder and oppositional defiant disorder, everything that I said about ADHD applies, although I think psychotherapy is more important with those children. In children who do not have ADHD, the question is much more complicated in terms of whether or not medication makes sense. And this is both because the data on psychotherapy are stronger than they are when ADHD is present, but also because the data for medications are weaker. Next slide. So in the area of conduct and oppositional defiant disorder, unlike in the area of ADHD, medication really comes up much more in children who have treatment resistance. So, there's some debate about what the first line treatment of conduct and oppositional defiant disorder would be, but it's clearly nothing like ADHD, where I gave you a very strong statement about the need to use psychostimulants. That's clearly not the case in conduct and oppositional defiant disorder. And many people argue that parent management training is really the first line treatment in these children. And I wouldn't disagree with that. Probably the second line, particularly in children with ADHD, but even in children who have, say, some but not all features of ADHD, again, stimulants are a reasonable thing to try. All right. So again, in this area, much like in the last one, you know, the first thing to do and the second thing to do are both pretty clear. You start with psychotherapy, particularly in a child without clear ADHD. If the child doesn't get better, you think about stimulants. All right, and then what do you do? So this is a second of these big trials. This is called the Tosca trial, and this looked at children who continue to have symptoms of conduct disorder after they had been treated both with stimulants and with parent management training. So what this shows you, it's 168 kids. They all had already gotten parent management training, and they all had already gotten stimulants, and they were still affected, and they were randomized to either placebo or treatment with risperidone. So risperidone is an atypical antipsychotic medication, and that is the one group of medications, antipsychotic medications in general, but atypical antipsychotics in particular, specifically risperidone, where they have been shown to have benefits for persistent symptoms of oppositional defiant disorder and conduct disorder. Now, there's a few problems with these data. One problem is that the atypical antipsychotics have a troublesome side effect profile. And it's troublesome because there can be some relatively severe, relatively persistent side effects that you can see with the atypical antipsychotics. The two biggest ones are something called tardive dyskinesia, and that's a neurological condition that children can get, which involves abnormal movements, typically tremors or twitches. This can be persistently long-standing. And then another associated side effect is what has sometimes been called the metabolic syndrome. And this is a combination of effects on metabolism that lead to things like diabetes, obesity, high blood pressure, and problems with the liver. Now, these are both serious and not easy to reverse problems. The other thing to say about these side effects, however, which in some ways makes them even more troubling, they're what we call indolent, which means unlike the side effects with the stimulants, which you tend to see right away, that's not the case with these side effects. They tend to arise very slowly. And it's very easy to miss these. So, you know, there's really two things as a psychologist that you really need to think about with these medications. So one is that when you're talking with parents about children who have different kinds of behavior problems, the discussion is very different when you're talking about the stimulants, where they've been around for a long time, and we know a lot about their safety, and the side effects are relatively clear when you get them versus the atypical antipsychotics. They've been around for a long time, but there's much less data, and the side effects can really sneak up on you. So that conversation is very different, number one. Number two, we have a tendency to get complacent when we put children on these medications, partly because they can be quite helpful, particularly with kids with severe impulsivity and severe aggression. But beyond being careful with that initial decision, this is the kind of thing where you really need to be thinking about, is a trial off the medication really warranted? And that's mostly because these kind of indolent and relatively persistent side effects that we can see with the atypical antipsychotics. All right, I'm gonna pause there for a minute just to see if anybody has any other questions about any of those. Stacy?
No questions coming in yet.
All right. All right, next slide. All right, so we've talked about ADHD, we've talked about conduct and oppositional defiant disorder. The decision there is reasonably straightforward in that it's pretty clear with ADHD that you start with a stimulant, and if you're a therapist who's seeing a 7 to 10 year old child and they clearly have ADHD and they haven't at least considered stimulants, you need to think about that. On the other hand, if you're seeing the child with conduct or oppositional defiant disorder and they don't obviously have ADHD, you can feel okay. Things get pretty murky in this third one, major depressive disorder. So let's talk about major depressive disorder. And next slide. So this is a very serious disorder. In some ways, it's different than either ADHD or conduct disorder, in that on the one hand, it can remit. So unlike either conduct disorder or ADHD, which tend to go away fairly gradually and slowly, major depressive disorder can remit and it can completely go away on the one hand. On the other hand, we're not talking about the large scale efficacy studies only of the medication, but beyond the studies that I'm going to talk about, there were a number of studies on the treatment of major depression during the same time period in the late 90s and the early aughts. And they showed that the response to major depression typically did not involve complete remission of the disorder. So this is a disorder that we're really concerned about on the one hand in terms of treatment. Number two, though, however, not only is the response to medication not that great, but the response to psychotherapy is also really not that great. So major depression is really a very serious disorder. And when you see a kid who you think has major depressive disorder, alarm bells could kind of go off. So there have been a couple of comparative efficacy studies, but the most important one is shown on the next slide. Next slide. Oh, so this summarizes what I basically just said. This is a bad problem, and they're pretty bad options here, in that both psychotherapy and medication, they're not great treatments. And the main study we know this from, next slide, is something called the TADS. You can see it listed there, TADS, Treatment of Adolescent Depression Study. This is the main big comparative efficacy trial for major depression in children and adolescents. And this used 4 different conditions: CBT alone, SSRIs alone, placebo alone, or combined SSRIs and CBT. And this is another one of those studies, a little bit like the MTA study, that is somewhat controversial in that the message that came out of this study, I think, is not totally accurate. The main message that came out of this study was that combined treatment was the best treatment. But I think that's not completely accurate for reasons that I'll talk about in a second. The other thing to say is that there have been other studies that have been done since the TADS study that are similar to the TADS study. I think they're not as strong, and maybe they provide a little more optimism about CBT. But the bottom line is that neither treatment, CBT or medications, are great treatments for major depressive disorder on the one hand. On the other hand, if you have a child who has, or an adolescent who has clearly has major depressive disorder, the data aren't quite as clear as they were for ADHD in terms of the need for medication, but they're pretty close. And if you look at the lower left graph there, Stephanie? Yeah, put on the lower left. There you go. So you see there are 4 lines there. So those top 2 lines, yeah, those are 2 lines there. You can barely tell. All right, it looks like 1 line. That shows you the reduction in symptoms over the life of this trial on those 2 lines. One of those lines is placebo, all right, and one of those lines is CBT alone. So there's kind of 2 ways that you can look at this. One is that this is really bad news because CBT doesn't beat placebo, all right? This is the only trial that's compared CBT head-to-head with placebo in the treatment of major depression. And this is pretty bad news for CBT. On the other hand, and when you look at that line, it does go down quite a lot. So you could also argue, you know, that major depression is a disorder that is quite susceptible to what we call expectancy or suggestions of improvement. And we could debate what this means, but my takeaway is plain and simple: CBT did not beat placebo. On the other hand, when you look at those other 2 lines on the bottom there, those are the 2 lines of fluoxetine alone. Yeah, the top one, that's fluoxetine alone. The one below it is fluoxetine plus CBT. So both of those lines are lower than the other 2 lines. So medication, it beats placebo here, even though CBT didn't, all right? So this provides some evidence of why you really need to think about medication, because kids on medication did better on kids not on medication in this study. Now, as I mentioned, this is somewhat controversial, and it's controversial because when this study came out, and people still talk about it this way, people made a very big deal about the difference between those bottom 2 lines. So Stephanie, highlight those bottom 2 lines. Yeah, see that little difference there? The one on the bottom, yeah, there you go. The difference between those 2 lines, that little teeny tiny difference, that's the difference between CBT plus SSRI versus SSRI alone. And it is true that is different. And people make a big deal out of it. People like me, however, think that this difference really should be discounted. Besides the fact that it's so small, does anybody know the difference? There's a very important difference between those bottom 2 lines. Does anybody know what it is in terms of the design of the study? Just speak out if you know the difference. Stacy, do you know the difference?
You put me on the spot, Danny.
I am.
I don't know the difference.
All right.
Help me out, team.
Does anybody else know? Abigail. Nobody.
I was gonna say, let's call out Abigail.
Yeah, Abigail.
No one else is
right.
offering any ideas.
So in that bottom cell, people were unblinded. They were told that they were on medication. The people on the other line were blind. Yeah, they thought they might be on placebo. So my argument is that that little difference is likely to be due to expectancy, as it. I'm sorry. That was mean. I try not to be mean. Anyway, but the bottom line is major depression is a really bad thing. We should all wring our hands when we get to it. Particularly if it's very clearly the diagnosis of major depression and there's any thoughts about severe impairment or suicidal ideation, the child really needs to be on medication, and you know, you need to have a discussion about that. All right, next slide. All right, so we're going to go through, there are 2 more things we're going to go through. We're going to spend a little more than 5 minutes on this 4th one. And I'm going to tell you the data are roughly similar between anxiety disorders and OCD. So I'll talk a little bit about the difference. And here, the story is also different. All right, so we talk about one story with ADHD where you really need to think very seriously about stimulants. We talked about another one with conduct disorder and oppositional defiant disorder. where it's okay as long as the child doesn't have horrible ADHD to hold off on stimulants. We just got done talking about major depression, where you really need to think very seriously about SSRIs. Anxiety and OCD, and we're going to talk about the data. These are those areas where you're really okay holding off thinking about medication, and we're going to talk about the studies that support this. And there are 2 or 3 things that go into this. One thing is that when we think about the long-term outcome and the risk for serious adverse consequences, compared to major depressive disorder, we worry a little less about anxiety disorders and OCD. They tend to have better long-term prognosis. So it makes us feel a little more comfortable not throwing everything at a child that we could possibly to try to help them get better. So that there were a few trials, actually 4 trials sponsored by the government that look at either anxiety disorders or OCD, and the results were really the same in all 4 trials. This one is the CAMS study, Child and Adolescent Multimodal Study for Anxiety. And this was in a group of about 500 kids who had anxiety disorders. And if you look at the top right there, exact same design. This had the exact same design as the TAD study. So you want to highlight the top right there for me, Stephanie? Yeah, there you go. And if you remember, not on the right, go to the right. There you go. So those are the same 4 lines. And there are really 2 ways that this one's different. All right. First, look at the yellow versus the green line. All right. CBT beat placebo here. All right. And if you look at the yellow versus the purple line, that's the CBT alone versus sertraline. That was the SSRI alone. So, so here, those lines are not different, even though they look a little different. I'm not going to make a huge deal out of that, particularly because I have less concerns about the safety of the CBT than I do the safety of the SSRI. So psychotherapy for anxiety disorder is stronger than psychotherapy for major depressive disorder. And the reason I'm saying that is psychotherapy for anxiety disorders, CBT alone beats placebo. That's also true of OCD. We're going to talk about OCD in a second. All right, so that's one difference. And then the second difference, if you look at the purple line and the red line, the difference between those 2 lines is far more impressive. So if you compare kind of the average of the purple and the yellow, the difference between those and the green is roughly the same as the difference between the red. So we feel better about holding off on medication in a child with anxiety disorders than we do in a child with major depressive disorder. Next slide. So this is the one for OCD, and this one, I'm gonna ask a question about this one. So I'm not gonna call on anybody, but be ready to say something if you when I ask a question in a second. But here it's the same kind of thing. You got the placebo on the top. You see the upper right? Yeah, there you go. So you got placebo on the top, you got what we call the 2 monotherapies in the middle, and then you got the combined therapy on the bottom. All right. So again, this looks really, really clear. The data here are about as clear as you could ever want. All 3 treatments are clearly better than placebo. The placebo line is pretty flat. So compare that placebo line with the line in the TAD study. Remember, we talked about depression, how much that went down. It went down more than the line here. All right. And then the combined treatment is clearly better than the 2 monotherapies. Now, this study also is kind of controversial. Does anybody know the controversy behind this study?
I'm monitoring chat in case anyone has a suggestion.
All right. So the big deal with this one, and they kind of buried this in the paper, and haven't made No, good guess. Not about dropout rate. Dropout rate is one of the big bugaboos of these kinds of studies. Does anybody know what the other bugaboo is in these kinds of studies? So the big thing that kills you in these kinds of studies is what's called a site by treatment interaction. And what that means is that the effect of the treatment varied at different sites. And what often happens in a study like this, what would you think? What would you think would be the what would you think would be the biggest difference among the 4 different treatments where they would vary across site? What would you think? Which group would vary the most? Somebody put it out there. You guys are psychologists. You should know this. Come on. The psychotherapy group. There tends to be huge. Yeah, there you go. Thank you, Jason. The psychotherapy groups tend to differ. And you can imagine why that was. So that was the case in this study. And these data average across the sites, really don't look like any of the data in any of the sites, all right? In one of the sites, psychotherapy alone was the best treatment, all right? And psychotherapy alone beat medication, all right? In the other site, medication beat psychotherapy alone. And it was only when you averaged all the sites together did you get something that looked like this. So, you know, for OCD, what I would say is therapy is the first line treatment. I feel pretty confident, particularly in OCD, that you should really start with therapy. I also feel that way about anxiety disorders, but particularly in OCD, that's only if you can really do appropriate exposure with response prevention. All right, next slide. Yep. Want to keep going, one more. All right, last thing we're going to talk about is autism spectrum disorders. So autism spectrum disorders are different from all the other disorders that we're talking about. And the main reason they're different is, unlike all the other disorders, up until this point, we've been talking about core features of the disorder. So remember when we talked about the MTA study, I highlighted symptoms of hyperactivity and impulsivity. That was really the core feature of the disorder. Now, I didn't say this about the other, go back. I didn't say this about the other 3 conditions, but the same was the case for these other conditions. This is not the case with autism spectrum disorders. So repetitive behaviors and problems with communication are the core features of the autism spectrum disorders. There is no medication that has been shown to be effective for autism spectrum disorders in terms of the core features. There's one FDA indication. Does anybody know what the FDA indication is for a medication? So it's for irritability, for atypical antipsychotics. All right. The other thing that has been studied, there have been stimulant trials of symptoms of ADHD in children with autism spectrum disorders, and there have been no, it's risperidone. There have been trials of SSRIs for obsessive concerns that are associated with repetitive behaviors. Next slide. So this shows you the results from the citalopram trial. This was published about 5 years ago. And this shows you a comparison of citalopram on symptoms of obsessions and compulsions that are associated with repetitive behaviors in autism spectrum disorders. And as you can see here, there's absolutely no difference in terms of the effect here. So when you're thinking about medications for autism spectrum disorders, unlike ADHD, which we really started with, you really shouldn't think about medications until a child has failed psychotherapy for autism spectrum disorders. So next slide. So we've really run the gamut in terms of me giving you kind of an outline to how to think about medication. Probably the one big overarching thing that I would say is that the disorder you're thinking about really matters a lot, both because of this idea that we think about disorders and treating them relative to how severe they are and what's the likelihood that it's going to go away on its own, but also because we find quite different things in terms of the comparative advantages and disadvantages of medication over psychotherapy. For some of these conditions, definitely OCD, probably the anxiety disorders, arguably cognitive disorder without ADHD, clearly psychotherapy is the first line treatment. For others, such as ADHD, psychotherapy is clearly the second line treatment. And for others like major depressive disorder, you know, it's a little less clear. So I think with that, those were the main things that I wanted to say. Why don't I open it up to any question that anybody has really about anything?
Yeah, I mean, I'm gonna go back to the question emailed yesterday too, and also just to follow up on that. So with medications in any of the classes, what about how would we talk to parents who are concerned that the medications might affect their child's personality?
Yeah, well, so, you know, it all matters what we mean by personality. This has been a kind of chronic concern of parents, and you can definitely hear it from older kids for some medications. There are two things that I would say about this. The first is that there is not really strong evidence for really any of the medications that they do this. Probably the place where the evidence is the clearest is the atypical antipsychotics, although the evidence is also pretty clear for the stimulants, where the children can seem less spontaneous or sedated is often where this is how this is rated, and that clearly can happen, but that's typically relatively rare with a lot of these medications. But then the second thing to say is, for all of the medications, this is completely reversible, and particularly with the stimulants, it's the kind of thing where it's pretty easy and pretty quick to figure out, is the benefit worth the cost? You know, it tends to be a concern that rarely impacts long-term treatment. Some of the other things that we've talked about tend to impact treatment more quickly.
I'll throw out another question for you too. I don't see any others coming through, but so we're talking about like all of these diagnoses sort of individually. Are there any medication considerations when kids present with multiple diagnoses, or do you follow the same decision tree?
Yeah, in general, you follow the same decision tree, mostly because there have been far fewer studies like this that have been conducted. There have been a couple on bipolar disorder that look at how to handle this issue. There have been a couple on the combination of ADHD and anxiety. And there have been a couple on ADHD with ODD. But none of the messages from any of those really changes anything that I've said. Treatment refractoriness in general is really difficult to study unless it's a very common thing, like in schizophrenia. Schizophrenia is an area where there's been a lot of work on treatment refractory schizophrenia. And there is some evidence that clozaril or clozapine is particularly effective. And then major depression is another area where there's a fair amount of work, but even there, it's not that clear. I mean, ketamine is probably the most obvious area.
I don't see any other questions.
All right. Well,
We're right at
Stacy,
2.
yeah, and you'll get back to me about what we want to do on the next one, and maybe reach out for the date and the topic, and maybe.
Yep.
a month or so.
I think we'll,
All right.
just for everyone's knowledge, we'll probably plan the next one in September as usual, and we'll let you know the topic for that. If you have any requests, just send me an email and let me know. Thank you, Danny, and thanks everyone for
right.
joining. Look
Sure
for your
thing.
inbox for the
All
evals
right.
and the
All right.
certificates.
All right.
Bye.
Bye-bye.